and lower HDL, a very similar picture to that seen with the metabolic cluster. Another measure of subclinical atherosclerosis is that of arterial stiffness, and one methodology which has been used in the past to measure arterial stiffness is that of applanation tonometry. Arterial stiffness has been shown in adults to predict cardiovascular events and mortality independent of other traditional risk factors. This has been shown in adults, but also in children, particularly those at high risk, including obese children and children with familial hypercholesterolemia. Studies from the RAIN study show that those in the high metabolic risk cluster have high levels of have a higher pulse wave velocity in both sexes, and in males, those in the high metabolic cluster had a higher augmentation index, but this was not seen in females. Intermedial thickness is another measure of subclinical atherosclerosis. Sonographic evaluation of the arterial wall morphology and elasticity is increasingly accepted as a non-invasive tool in cardiovascular assessment and is thought to reflect different vasculopathic processes in children. It's been used now quite extensively in children, and this particular study shows in children with an average age of 11 that those with type 1 diabetes and hypercholesterolemia have significantly higher aortic IMT compared to the control group. The increasing use of IMT has in fact driven the need to develop normative values for IMT thickness in adolescents and children, really reflecting the increasing understanding that it is a useful measure to use in children. Finally, we're going to move on to discussing the application of these cardiometabolic assessments to understand DOHAD principles. I'm going to divide the results into three groups, looking firstly at factors predisposing to the cardiometabolic risk cluster, secondly looking at the childhood adiposity trajectories and their relationship to outcomes such as blood pressure, and thirdly looking at what comes before these adiposity trajectories, what early life factors predispose to these trajectories. To remind you, the high and low risk clusters are shown here. This was performed at 8 years in the RAIN study. And you can see in this figure here the quintiles of birth weight along the x-axis and the proportion in the high risk of the metabolic cluster along the y-axis. You can see that those who are lightest at birth in quintile 1 and those who are heaviest at birth in quintile 5 have the highest proportion with the metabolic syndrome cluster. In other words, those who are lightest and heaviest had the greatest subsequent metabolic risk. At the time this was published, we believe it was perhaps one of the first studies to show that this U-shaped relationship in a Western population rather than a transition population such as the Pima Indians. In addition, we saw that early life factors such as maternal smoking during pregnancy, postnatal weight gain, and breastfeeding all affected the risk of developing the metabolic syndrome or metabolic cluster some 8 years later. I'll now go on to discussing the childhood adiposity trajectories. As you recall, this was derived from adiposity Z-scores over 8 time points between birth and 14 years using semi-parametric mixture modelling. Blood pressure was also taken at 6 time points between 1 and 14 years. I'm going to stick to the same colour coding of the yellow, green, blue and red for the remainder of this talk. You can see in this figure that the trajectories corresponding to yellow, green and blue, so in other words the yellow trajectory which is shows chronic high adiposity, The green and blue trajectories, which are both rising trajectories, were associated with greater levels of HOMA, indicating greater insulin resistance in these adiposity trajectories. This was a similar picture seen for systolic blood pressure, where you can see on multivariate analysis that the beta coefficient was between 4 to 10 millimetres for the same three trajectories. To put this in context, this level of change in blood pressure is associated in adults with a change in 1/3 of stroke risk, so certainly is clinically significant at 14 years of age. A similar picture was seen when this was related to prehypertension and hypertension, which were both categorised according to J&C criteria. You can see that there was an increased risk in the yellow, green and blue groups for prehypertension and hypertension, as well as for the global cardiometabolic risk, which was measured by the risk cluster analysis. A subtle but I think very interesting and important nuance is shown here in the red circle. You can see that, well, here in the red circle there was a sex by trajectory interaction on the outcome of cardiometabolic risk. And what we saw was that, in fact, the dominant effect of this trajectory was only seen in males, which I think is very important to note. The blue trajectory is, in fact, a trajectory which probably most closely reflects the original Barker trajectories, i.e. from a low birth size rising with postnatal catch-up growth. And many studies, animal studies and increasingly human studies, are showing sex differences in programming effects. We then looked at the adiposity trajectories using linear mixed modelling in relation to longitudinal blood pressure. Once again, on the x-axis is age in years from 1 through to 17 years, and this time along the y-axis is systolic blood pressure. You can see that the longitudinal adiposity trajectories are related to the longitudinal systolic blood pressure groups, and that on cross-sectional analysis, the yellow and green groups were already quite different from the reference red group as early as 3 years of age, so as early as preschool age. So the summary of this section of the talk is that 7 adiposity trajectory groups were seen. 31% of them belong to the chronic high and rising trajectories from either low, moderate or high birth weight. And it's important to emphasise that these rising trajectories were irrespective of whether they came from a low, moderate or high birth size. In addition, early life factors were shown to predispose to these trajectories. Just to bring you back to this schema, you recall the green writing refers to early factors such as maternal environment, which could affect early life programming. And indeed, we did see that factors like gestational diabetes, maternal hypertension, and maternal weight gain through pregnancy were associated with the yellow trajectory, or trajectory 1, which reflected chronic high, lifelong adiposity. And breastfeeding of short duration was also increased the risk of being in this trajectory. Maternal obesity was associated with the yellow and green trajectories, and maternal smoking with trajectory 4. So in closing, the key research findings from the RAIN study are that there was a U-shaped relationship between birth size and metabolic risk, and of particular note because this was seen in a Western population. And when we could probably correlate the high and low birth size with the longitudinal growth trajectories related to chronic high adiposity, as well as rising postnatal adiposity, and this was irrespective of birth size. We also saw that early life events such as maternal obesity, gestational diabetes, gestational hypertension, breastfeeding duration and maternal smoking during pregnancy were associated with these adiposity trajectories, as well as the metabolic risk cluster. As closing statements, really to open the discussion, I'd like to say that I'm sure we all agree in this room that assessing thoughtfully and carefully assessing cardiometabolic risk in children is important, particularly with regard to understanding DOHAD, and that it can either be a predictor or an outcome. When assessing obesity, longitudinal techniques should be considered and are likely to be very useful, and that when assessing metabolic syndrome in children, data-driven techniques such as cluster analysis should be considered. I'd like to thank my collaborators and funding bodies, as well as the families and children, young adults of the RAIN study. Thank you.